Welcome back to my channel with the new video, and again this particular topic which I will be deliberating upon is the practice changing papers related to the nutrition in shock, which I deliberated during the recently held National Annual Critical Care Conference 2025 held in the God's own country, that is Kerala, in the city of Kochi. So again we will divide it into two parts, and I will be able to give you the glimpse of what is the current evidence as regards nutrition in shock. And let us start with the topic. So just a background of shock that we should know, where this patient of shock can have a the splanchnic redistribution and the compromised splanchnic circulation. Also, there is something called as translocation of bacteria, uh, which will have a propensity for sepsis in these kind of patients. There is a bit of enterocyte edema, and of course the gut dysmotility. So all in all, this is a catabolic process which is seen in any critically ill patient, especially even the patients of trauma, those who are in shock. So here we are comprehensively discussing about any etiology of the shock, but predominantly it would be septic and cardiac. So when we talk about shock, we obviously are concerned about how much is the vasopressors being delivered to that particular patient, and what does a vasopressor do to the GIT. So the first and foremost statement which I want to make is vasopressors plus inotropes are more deleterious to the GIT. And here you can see, except low dose dopamine and dobutamine, which will increase the GI perfusion, almost all the other agents will have an impaired GI perfusion. So this has to be bared in mind. Now, if we talk about EN, that is enteral nutrition in shock, and we should be aware of even there are some potential problems related with EN in shock, and of course the beneficial effects of EN in a patient who is on vasopressors. So we'll just come to that. But before that, we should be aware of the fact that early enteral nutrition may induce intestinal hemodynamic changes, as we know that there is a redistribution of the blood flow to the splanchnic circulation, and from there can be redistribution, so it can cause intestinal hemodynamic changes. It can cause reduced blood flow along with disparity in oxygen delivery and the consumption, and of course mesenteric ischemia and necrosis. So this notion that we should use gut is something which we should be aware of the fact that they can actually help, but at the same time we should be aware of the potential problems. Now, as far as the benefits are concerned, it will improve the intestinal mucosal injury with microcirculation and of course the perfusion. It will improve the immune milieu of the gut. It preserves IgA and impact on the antibiotic resistance, and it has been shown to increase the cardiac output, decrease the systemic vascular resistance, thereby increasing the mesenteric blood flow even if the patient is on vasopressors. So this is from the Clinical Nutrition ESPEN Guideline 2024, which talks about benefits of the EN. As far as the international guidelines are concerned, where we know that on the background of the requirement of optimum calories and the protein, especially in the acute phase of critically ill patients with MODS, which is so very crucial, the question is whether we really achieve it. And the fact that The greater calorie and high proteins will have a major impact on morbidity and mortality of the patient. That is well understood. We talk about 20 to 25 kilocalories per kg per day of calories and 1.2 to 2 grams per kg per day of proteins. And this has been our understanding since last about 10 years, discussing and deliberating upon the right doses of calories and protein, but the question is whether we really achieve it. And on the top of that, to add fuel into the problem, there are conflicting results and controversies, especially related to the papers which come out and talk about decrease in the mortality in the patients who have increased calories and protein. There are few papers and studies which show no difference in mortality, and of course there are the evidences which have come out regarding the early enteral nutrition in septic shock, which talks about increased morbidity and mortality. So obviously there are conflicting results and the controversies which definitely exist, but we will try to unfold and give a clear cut message. As you could see from this slide, that the initial of 24 to 48 hours we usually wait for the EN, and then after 48 hours you start the EN. But we need to be very careful and have a screening for refeeding syndrome, especially between the third and the fourth day. It is very clear that every patient who is critically ill probably receives supplementation of thiamine in a dose of 100 to 200 milligrams IV per day from say around 5th or 6th day onwards, and of course the supplementation of multi micronutrients in the parenteral form after 6th or 7th day. And here I would like to kind of introduce you to two terms, that is NOMI and NOBN. It stands for non-occlusive mesenteric ischemia and non-obstructive bowel necrosis, and they classically present with abdominal pain, distension, peritonitis, GI bleed, multi-organ failure, air in the intestinal wall, portal gas, and these are the conditions where enteral nutrition is absolutely contraindicated, or if the patient develops either of these, we need to actually stop the enteral nutrition whenever you come across NOMI or NOBN. So I think I'll stop at this point in time, and then in the next part 2 video, that is the final video for the nutrition in shock, and we will discuss about the evidence, the current evidences, right starting from 2014 till date, and of course with the ESPEN guidelines. So that's all for now. Bye bye, take care.